At our center, and I'm sure a lot of expert centers around the country, we see a lot of people who are diagnosed with Parkinson's disease who actually have an atypical Parkinsonism. And the word Parkinsonism really refers to slowness and stiffness. So any individual who has slowness and stiffness can correctly be said to have a Parkinsonism. And then the question is, what Parkinsonism do they have? There are medications that can block dopamine. These are medications that are neuroleptics that reduce hallucinations. There are some anti-nauseants that can block dopamine. So those would be examples of medication-induced Parkinsonism. But there are also a group of degenerative neurologic disorders that are called the atypical Parkinsonisms that differ from Parkinson's disease in several important ways. Parkinson's disease is usually an asymmetric disorder. It usually starts on one side and one side is worse through the course of the disease. We look for at least 2 out of 3, slowness, stiffness, and tremor. And very importantly, we look for improvement with the introduction of dopamine medication. If there's sufficient slowness and stiffness there, we expect to see improvement. Tremor is tricky because tremor sometimes responds great to dopamine medication, sometimes doesn't respond at all, or can be in between. So we're looking for an improvement in slowness and stiffness. I always like to try and teach our students that it's important to listen for improvement in motor features, because sometimes patients will say, well, my energy feels better, or I can think better. I'm not really sure I know how to interpret that. I'm listening for is the slowness, the stiffness, the mobility, walking, are those motor features improved? And if they are, that would be a pretty good indication that we're dealing with Parkinson's disease. On the other hand, these atypical Parkinsonisms, those individuals, not only are they losing dopamine neurons, they're losing the neurons that receive the dopamine. So when we add dopamine medication, the dopamine in the brain may increase, but the dopamine can't be received. It can't stimulate the subsequent neurons to activate and improve the slowness, stiffness, and tremor. So in those cases, whenever we hear, well, the patient was put on reasonable doses of dopamine medication, especially levodopa, didn't improve, one of the things I think about is, does this patient have an atypical Parkinsonism? Now, the atypical Parkinsonisms also differ in their clinical appearance from Parkinson's disease. They tend to be rather symmetric from side to side. Usually there's little or no tremor. They tend to have more stiffness in the neck than in the hands. They tend to have early speech and balance problems. If a patient comes to our center and they say, oh, the first thing that happened is I developed balance problems, and especially if they're having falls within 1, 2, 3 years, that would be a good indication that the correct diagnosis is not Parkinson's disease, but probably one of these atypical Parkinsonisms. And as I mentioned before, if patients are placed on dopamine medication, especially levodopa, typically there will be little or no benefit. Sometimes one sees some benefit early for the first 6 months to a year that then's lost in these atypical Parkinsonisms, but generally you see little or no benefit. So what are these? Well, one is called MSA, or multiple system atrophy, and that's because multiple neurologic systems in the brain are affected. So you have the basal ganglia system, which controls the motor system or modifies the motor system. That's what's causing the slowness and stiffness. You also have, very importantly, the autonomic motor system, which controls the automatic part of the nervous system. So these are things you don't have to think about. So things like heart rate and bladder function, you don't have to think about very much. So people with MSA often will note that they have urinary incontinence. Men may report erectile dysfunction. When individuals get up, they may say they're lightheaded because the body's response to standing up and squeezing the blood vessels to keep the blood getting up to the brain is impaired. So the autonomic system is involved in MSA. Some patients with MSA also have problems in the cerebellar system, or the balance system of the brain. So they may walk with their legs wide apart. Not everyone, but that may be a symptom. Balance may be impaired as well. And then another part of the system is really on the examination part. When we test reflexes, they may be increased. So these are some of the systems that are involved, and that's why it's called multiple system atrophy. The other common one is called PSP, or progressive supranuclear palsy. These individuals tend to get bad balance problems quite early on, and usually the rule is they have falls or experience falls within the first year. Often there's a lot of stiffness in the neck. There may be a fair amount of speech involvement, And one of the key features on examination is eye movement abnormalities, particularly difficulty for the individual moving the eyes downward, and again that can be seen on examination. Unfortunately, these disorders are very difficult to treat. Usually what we do is we try to get anything we can out of levodopa. We'll take the dose up and up and up to a very high dose, see if we can get any benefit. If there's no benefit reported, then we'll take the dose down and down and down and even stop it, and we'll ask, is there any loss of benefit? A lot of patients say they notice some loss of benefit going from about 400 to 600 per day down to 0. And if they do notice a difference, then we'll go back to the 400 to 600, whatever they felt helped them the most. And then the other medication we've had some benefit with is amantadine. Now, amantadine is an interesting medication. How it works exactly is not clear, but it may help release dopamine, and it may have other ways to act as well. The negative about amantadine is it's pretty good at inducing confusion and hallucinations. So if someone already has confusion and hallucinations, I wouldn't use the medication. But if not, and especially if the person's having gait difficulty, it's really the best medication to try. You start at a low dose and slowly go up, but it certainly is possible to get confusion or hallucination, so one needs to be prepared for that. So I think that's sort of an overview of the atypical Parkinsonisms. They're a tough set of disorders to treat, very commonly misdiagnosed, but I think once they're diagnosed, one can approach them a little bit more accurately with regard to medications.